This is Dr. Andrian over at the Center for Hip and Knee Replacement, and today's talk will be a far more technical talk addressing the problem of severe flexion contractures in the Mako knee replacement or robotically assisted total knee replacement. This talk is geared mostly toward our healthcare provider audience, but if you're a patient or somebody who's interested in knee replacement, you're more than welcome to listen in. We're going to be very technical as we talk about the specifics and the math behind the numbers used in dealing with severe flexion contractures. Okay, we'll start out with a patient with a severe flexion contracture. So we can tell when we look at his films, we're looking at the anterior and the posterior. We can see his tricompartmental disease. We can see his lateral subluxation of his tibia. And if we look at the lateral, he's got severe patellofemoral arthritis with bone spurs or beaking, both in the patella as well as the femoral trochlea, and he's got large posterior osteophytes. So he clearly has a bad knee. We know it's stiff on clinical exam. We can see the associated osteophytes in both planes. And then on top of that, he's also stiff just because he has Parkinson's. He has an underlying rigidity, and he has something that compromises his balance. I'll show you how we deal with the mechanical rather than the neuromuscular aspects of his stiffness. All right, the first thing that we always have to do whenever we're dealing with stiffness is once we've characterized the knee is to understand what is creating tension in the ligaments. And we can see from our three-dimensional formatting, I know exactly where all the osteophytes are ahead of time. So we have a 3D construction in the coronal, in the axial, and the sagittal plane. I can see the osteophytes around the trochlea that I saw before and along the medial and lateral condyles. And very clearly, especially when I'm looking at the sagittal view, I can see these large osteophytes that need to be removed anteriorly and posteriorly. So this is the first step that has to happen. So once the knee is open, the femur and the tibia are exposed, we start taking down the osteophytes to decompress the tenting on the capsular ligaments. And after that, we'll start with our baseline. So even before we get a baseline range of motion, we will start decompressing the knee, and it's very helpful to know ahead of time exactly where the osteophytes are so we can go after them specifically and deliberately. Now, this is an extremely stiff knee, so now the osteophytes have already been removed, and here we have a 28-degree flexion contracture, and this is a very stiff, fixed deformity. Oftentimes, I'm able to push it down with pressure down to the 20s or even to the teens, but this is a very, very stiff knee. So we're starting at 28 degrees, doesn't move very much. If I put all my weight on it, I can capture a number at 1711. Now, the importance of this number is it tells me the angular deformity I'm starting with in the coronal plane. So I can see that the knee is in varus. I already know the knee is in varus from x-rays, but I can see it's got a 6mm asymmetry in varus. Now, getting the flexion is relatively straightforward because even if it's stiff, I can still get 90 degrees and I can capture a pose, 11 and 10. So this two-plane deformity, both the varus and the flexion contracture, are going to be the most difficult things to deal with in this portion of the case. I'll show you how we manage that. We know whenever we're balancing a knee, there are three ways that we can do it to plan our cuts. One is the robotic way of using an 18-18 heuristic on the box. Another is measured resection, and another is gap balancing. Because we're so tight, we're not going to be able to use the 18-18 because we just can't get that measurement. So we're going to do this in its two-stage plan. Stage one will be using a measured resection technique, and then we'll use gap balancing for our fine-tuning. So again, the first part is to use measured resection, and then we'll use gap balancing for fine-tuning with our trials and with our lamina spreader once the cuts have been made. Okay, so the first thing that we're going to do is a measured resection technique. We know the thickness of the implant is 8mm in the femur and a composite of 9mm in the tibia. So if we look at the femoral component, first we'll take 8mm, okay, and then because that's what we'll be replacing. We look at the sizing, medial and lateral, and then we can look at maintaining the posterior offset. So here I know the sizing, and I know the depth, and I know I made sure that I maintain my posterior offset and maintain the radius of curvature. Okay, and then on the tibial side, I know the composite thickness is about 9mm. The lateral side is always higher on a varus knee, and so I'll set it at 7.5 with a neutral rotation and a 3-degree slope for a cruciate substituting design. once the cuts have been made using a measured resection technique, I will first start working for ligament balance in flex posture. So the knee is brought to 90 degrees. I'll put the laminar spread in. I'll prepare the back of the knee in the standard fashion, and then I'll get a recording. So here I can see the back of the knee on the medial side is 18-20. So I still have a 2 millimeter asymmetry in my gap. So I have more than enough space now for an insert, but I have an asymmetry. So what I'll do is I will recess the PCL attachment off the PCL origin off the femoral notch. Remember, the PCL is a varus stabilizer in addition to the MCL. And so if I do that very gently, then I can go millimeter by millimeter until I have a symmetric flexion gap of 20 and 20 on both sides. So now I have restored and prepared a symmetric flexion gap. I'll then move into extension. So in extension, I'm doing the fine tuning here. So now I brought the flexion contracture over 21 degrees. So I started out with 28, now I'm 7. So now I am almost within a neutral range of extension. I have a 16 and a 17. It's still tight. I want to get another 3 degrees of flexion. So I need to open this up by about 1.5 millimeters. So I'll start making some fine tuning. Now, as I make this, when we go back to the tables of knowing where to take more bone, whether on the femoral side or the tibial side, we know that I have an adequate amount of space in flexion because we saw that from the prior slide. So I won't take it from the tibia, I'll take it from the distal femur in order to get that extra degree of motion and extension. So I'll start raising the joint line by about 1.5 millimeters. I'll show you in the next slide. Okay, so we saw on measured resection, I had an 8-degree resection, but I still had a 7-degree flexion contracture with the 16-17 asymmetric joint gap. And so what I want to do now is I want to raise this joint line by 1.5 millimeters. I know that's going to give me another 3 to 4 degrees of extension. 1 millimeter will not really change my extension, but will give me some laxity. 2 millimeters will give me 5 to 6, which is too much. So I'll take 1.5. So I will gently raise my joint line from 8 millimeters to 9.5 millimeters and then make the distal femoral cut. And again, remember, I don't have to do it on the tibia because I have a sufficient amount of space in a balanced extension gap. Okay, so then I'll make those cuts, and then now I can see I'm at an 18-18. So I've opened up my gap, I'm back to a neutral alignment, and I have asymmetry, or I have symmetry back to where I want to be in my target. Then when we look at the postoperative x-ray, I want to make sure that I'm in a neutral alignment, and then I have a symmetric space between the femur and the tibia. And then when I look over at the lateral, make sure I maintain my posterior offset and overall good alignment. So severe flexion contracture is one of the more challenging things to manage in robotic assisted knee replacement, sometimes because you just can't get a starting number. And so you'll have to switch tactics completely to a measured resection technique. The measured resection technique will get you close. Sometimes you'll get it perfectly, but oftentimes you'll be required to do fine tuning, inflection on the PCL, and also an extension with your components in place. And then at that point, you'll switch to a gap balancing method. And in using these more traditional methods, you'll be able to maximize the ability to quantitatively make small adjustments using the robot. Thank you very much.